pharmacists help correct it?
About 10 years ago, we just began asking a lot of questions about our osteoporosis care. And one of the questions that we asked was, why are we not using our DEXA machine in our practice? Because we have one, and yet the number of DEXAs that we were doing was very low. And so we put together a quality improvement team that was interprofessional, and we looked at a couple of things over time. And one of the things that we looked at was our screening rates. And so our screening rates for women, and we define that as women over 65 having had a DEXA scan in the past 2 years, were really low. It was about 25% of women in the practice that had DEXA in the past 2 years. And that was despite having a DEXA machine in the office. That was despite having a physician who is trained to read those DEXA scans and having an interprofessional team to teach our medical residents and faculty about how to manage osteoporosis. So I guess the point there is teaching, well, let me say that in a different way. I guess the point there is that having equipment in the office and having people who are dedicated to teaching doesn't always mean that you're going to have great quality care. And so we developed a screening intervention that did not rely on the physician or the pharmacist actually at all. And so it was our bone densitometer who did the screening interventions for us. And so every Monday, he would get a printout of all women over 65 who were coming for visits that week. And he would look to see, have they had a DEXA? And if they hadn't, then the baton got passed to the nurse when the nurse was seeing the patient, and the nurse would say, have you had a DEXA? And if the patient had, but it hadn't been in our practice, then the nurse was responsible for getting the results and updating the quality metrics in the chart. If they hadn't, then we had standing orders to go ahead and get one. And so using that screening intervention that didn't involve the physician, didn't involve the pharmacist in the practice, really involved other team members, took our screening rates for osteoporosis for women from 25% to 75% in a year. And so then we went on to develop an osteoporosis management clinic where anyone who had an abnormal DEXA screen came to an interprofessional clinic, and then we worked to improve the utilization of medications for osteoporosis, because we also looked at that. And even if they had a DEXA, we weren't doing very well with population health in terms of treatment. And so we've been able to improve those metrics as well. So now we're moving on to look at our fracture patients. So I know that how frequently to do a DEXA, particularly in patients with normal bone mineral density or patients with osteopenia, is controversial, based on that study out of UNC that demonstrated that if you had normal bone mineral density, it's going to take many years to develop osteopenia or osteoporosis. If you're already kind of on that slippery slope, you're going to achieve that sooner. So where we are right now is we're living in a land of uncertainty about how frequently to monitor DEXA scans in patients who don't have osteoporosis. But despite that, there's a large body of literature that says patients who have osteoporosis are undertreated, and that, again, after they have a hip fracture, that they may not get appropriate treatment. They may not get calcium and vitamin D. What they get is surgery. And so that's why we're taking taking the lead of other countries in the world who've developed those fracture liaison services, which is basically a transitions of care model for patients who've had fracture, to ensure that they have all of the quality of care metrics met for populations of patients, so that we don't have as many people refracturing. We've published our screening rates and our osteoporosis clinic model in a paper that we published in JAFA a couple of years ago that was just our experience with embedding pharmacists in the patient-centered medical home. And we've talked about those particular projects at both physician meetings and at pharmacy meetings. We're being a little bit more strategic with this particular project that we're working on to evaluate whether or not we need a fracture liaison service in our community in terms of the way that we're collecting data, so that we can have some stronger publications in that area.